Hello, welcome. With this video, I will introduce what is the quality of evidence. At this point, you have done all the right steps for a high-quality systematic review. You have defined clear eligibility criteria, conducted a comprehensive search, assessed the risk of bias, extracted data carefully, often in duplicate, and may even performed a meta-analysis. But even after all of that, the evidence you end up with can still vary in quality. Some results may be very reliable, while others may be much more uncertain. So, we need a structured way to answer the question, how confident should we be in these findings? And that's what the concept of quality of evidence is designed to address. You may have heard the description of high quality evidence or low quality evidence. It seems the quality of evidence is categorical or of different levels, but instead it lies on a continuum ranging from no confidence, that means zero confidence, on one end, and on the other end, we may be highly confident that the estimate is close to the true effect and 100% sure. However, we have to make some categories. So that's why we divide this continuum into different categories. And with the grade language, we use four categories from very low to low until moderate and high quality evidence. Please note this category is for convenience. And in reality, the quality of evidence, like I have emphasized, it is a continuum, not categorical. What do we mean when we talk about quality of evidence? When we talk about the quality of evidence, we are really talking about confidence. Specifically, confidence that the estimated effect is accurate enough to support a particular conclusion or decision. This is not about judging individual studies in isolation. Instead, we assess the entire body of evidence for a given outcome. Even if some studies look strong, the overall confidence may still be low if the results are inconsistent, imprecise, or biased. So, quality of evidence helps us answer a very practical question. Can we trust the evidence enough to act on it? And for example, here we have an example of weather forecast. And this person says, I figure there is a 40 chance of showers and a 10% chance we know what we are talking about. So here, 40% chance means the effect estimate, while 10% chance means the confidence on the effect estimate. And the 10% here indicates quality of evidence. That is not very high. Many people got confused with the concept of quality of evidence and the study quality. They are not the same. They are related, but they are not the same. Quality of evidence, it is a broader concept. It refers to our confidence in the overall effect estimate. It asks how certain we are about the results. How much trust can we place in the evidence as a whole? On the other end, study quality, or a relevant concept, is risk of bias, like we have introduced before. Study quality is about problems within individual studies. It focuses on study limitations, risk of bias, or systematic errors. So, they are not the same. This slide helps us recap what we have introduced previously in risk of bias assessment. When we assess individual studies, we are mainly concerned with the systematic errors that could distort the results or threat the internal validity. These biases can occur at many stages, such as how participants were selected, how outcomes were measured, whether important confounders were controlled, how complete the follow-up was, and how the data were analyzed, and even how the results were reported or published. So this is related to risk of bias or study quality. It is part of the consideration for the overall quality of the evidence, but it is not equivalent to quality of evidence. It is also important to point out that the quality of evidence is assessed by outcome. This is very similar to how we conduct a meta-analysis. In a meta-analysis, we don't pool studies in general. We pool results for specific outcomes. Likewise, when we assess quality of evidence, we don't give one single rating for the entire systematic review. Instead, we ask how confident are we in the evidence for this particular outcome A, and how confident are we in the evidence for this particular outcome B. For example, here, what we can see is from one single systematic review, we have moderate quality of evidence for 7-day point prevalent abstinence, and we have low quality evidence for withdrawal. This is because even within the same systematic review, the evidence basis for each outcome may differ. For example, for 7-day point prevalent abstinence, we have 8 RCTs contributing to the effect estimate, and with over 3,000 participants. And these studies may have different risk or bias profile or inconsistency or indirectness compared to another outcome, withdrawal, which has only one RCT with 967 participants. So naturally, each outcome will get its own quality rating, and the quality rating could be different even within the same systematic review. We use the GRADE approach to systematically assess the quality of evidence. The first issue to emphasize is the starting point for the quality of evidence assessment. The starting point depends on the study design that forms the evidence basis. For randomized controlled studies, the evidence that is based on randomized controlled studies typically begin as high-quality evidence, while the evidence based on non-randomized studies usually starts with low-quality level. From there, we evaluate several domains that can either lower or raise our confidence in the results. There are 5 main domains that can lead us to rate the quality of evidence down, including risk of bias, inconsistency across studies, indirectness of the evidence, imprecision of the estimates, and publication bias. On the other hand, for evidence based on non-randomized studies, there may be 3 domains that can increase our confidence in the evidence: a large magnitude of effect, situations where plausible confounding would actually strengthen the observed effect, and a clear dose-response relationship. Now let's go through some important domains. One of the key domains in the GRADE approach is risk of bias. As we have introduced before, risk of bias refers to systematic errors in how studies are designed, conducted, analyzed, and reported. These errors can distort the true effect of an intervention. For RCTs, common sources of risk of bias include failure of blinding, inadequate allocation concealment, incomplete reporting of outcomes, and losses to follow-up. So our assessment of risk of bias at the body of evidence level will depend on our assessment for the individual studies. When these issues are present in the included studies, our confidence in the body of evidence will decrease. However, risk of bias is considered along other domains. In our video about risk of bias, we talked about risk of bias is about internal validity, but we also mentioned another factor, external validity or applicability. This is related to another important GRADE domain, indirectness. It refers to how closely the available evidence matches the specific clinical question we want to answer. Issues with applicability or generalizability or external validity can reduce our confidence in how well the results apply to real-world practice. This may include whether the patients, interventions, comparators, and outcomes in the studies align with our target population and the decision context. Additionally, evidence can also be indirect if the comparison is not direct, for example, when the treatments are compared through a network rather than head-to-head trials. Another important GRADE domain is imprecision. Imprecision reflects how certain or uncertain the effect estimate is, and it is mainly judged by looking at the width of the confidence interval. When the confidence intervals are wide, the true effect could range from important benefit to little or even no important benefit, or sometimes even net harm. Imprecision is often caused by small sample sizes, few events, or large variability in the data. When results are imprecise, our confidence in the evidence is reduced. Another important gray domain is inconsistency. Inconsistency refers to how similar or different the results are across the studies. When study results point in different directions, or the size of the effect varies a lot, this lowers our confidence in the overall estimate. We often assess inconsistency using measures such as I-square, the heterogeneity test p-value, and by visually inspecting whether confidence intervals overlap and whether the effect estimates are similar. When substantial heterogeneity is present, subgroup analysis may help explore possible reasons for the differences. But if we cannot find plausible explanations of the heterogeneity, and then the quality of evidence will be rated down. To conclude, for our systematic reviews to be useful for clinicians and policymakers, we need to have clear, reliable summaries of evidence. And we need to understand not just what the results show, but also how confident we are in those results and how strong the resulting recommendations should be. That's why having explicit, transparent rules for evaluating the quality of evidence is important. And the GRADE approach provides a structured and systematic way to assess the quality of evidence and the strength of recommendations. However, this video does not include content about the strength of recommendation. If you are interested in it, I strongly encourage you to find great resources to learn by yourself. To sum up, in this series of videos, we started with defining a clear research question, then moved through literature searching, study screening and selection, data extraction and risk of bias assessment, and we also covered how to synthesize results using meta-analysis and how different methodological choices can influence the pooled estimates. And finally, with this video, we discussed how to assess quality of evidence, which is a critical step in translating results into meaningful conclusions. When we assess the quality of evidence, we are not only summarizing what the evidence says, but also communicating clearly how confident we are in those findings. This helps evidence users such as clinicians, policymakers, and guideline developers to make informed decisions based on both the results and the certainty behind the results. Thank you for watching.